Hello everybody. Today we have a bit of a different case for you. This case, if I drive around a little bit, is not breast. This actually is part of a very extensive head and neck case. But this is one of those lesions that I've seen a few of these now. And they're very rare, actually. So to see a few of them already, I think is pretty incredible. As I just drive around, maybe if we switch down to 2x, it might be a little easier to appreciate. On the top here, we have our surface that's largely denuded, and we see that there's a lot of pink, a lot of blue, and a fair amount of hemorrhage. So this stuff over here, this is a lot of hemorrhage mixed in with our lesion. Switching back to 4x. So this actually is a case of mucosal melanoma involving the sinonasal tract. So mucosal melanoma is extremely rare. It accounts for about 1% or so of all melanoma cases. And what's interesting about melanoma is that mucosal melanoma is that there's a slight female predominance. Most of these patients are going to be in their 60s, and you will see a very low percentage, like 3 to 4%, maybe even lower, that are going to be younger than 30 years old. And these actually originate in the mucosal melanocytes. So we often see those in the respiratory tract, in the GI tract, in the GU tract, and no one really knows why we have melanocytes in these non-continuous sites, but that's what they originate from. Okay, so when we're looking at respiratory, since we're in the sinonasal tract, they're actually far more common to be seen here, to be seen in the nasal, paranasal sinuses than in the bronchus, or even more rarely in the lung. And this is an important note when you're considering, okay, well, could this be malignant melanoma? Malignant melanoma loves to metastasize to the lung. So if you have a melanocytic lesion in the lung, far more likely for it to actually be malignant melanoma than a mucosal melanoma originating in the lung. But they do happen. Mucosal melanomas also account for about 80% of the melanomas that occur in the respiratory tract. So do keep that in mind. The most common sites in respiratory, so we have nasal, paranasal sinuses, but very specifically, the septum and lateral wall of the nasal cavity, those are the most common sites. And this lesion in particular involved, well, by the time we actually got it was involving septum, lateral wall, and encroaching on the anterior skull base. So very, very nasty tumors. So what are patients going to complain about as I come in, and we can take a look at some of the features. So paranasal sinuses, right? So nasal things. So they're going to complain about obstruction, like maybe, I know I tend to have a very nasally voice due to allergies and stuff, but they could complain about obstruction. But it will be unilateral, it won't be bilateral. So they'll come in saying, hey, doc, like I have a lot of pressure, or it feels like there's something in my nose. They might complain about epistaxis or nasal bleeds. And later on, as these tumors become more and more destructive, as you can see here, like they're just kind of invading everything, encroaching on everything, there's going to be potential for a lot of pain and even distortion of facial features in the late stages as these lesions just begin to expand. And obviously because of the proximity to the eye, so you need to think about eye things. So they might complain about diplopia or double vision, and maybe even like shifting of the eye as well. But eye features are relatively very rare. With this lesion in particular, it was fairly advanced and actually did form a nasal mass. Often these are going to be flat lesions. They can be polypoid, and they can be, brown, black, like we would think with a lot of melanocytic lesions. But they could also just be erythematous and ulcerated. And in fact, they often will ulcerate. So that's not something that should be considered a bizarre feature or anything. These lesions can also be amelanosic. Okay, so if you have a lesion that's ulcerated and it's just a little erythematous, then you might consider, hey, am I even looking at a melanoma? Because you're not going to see the pigmentation. And the other thing is when they're amelanocytic. Sorry, I know I keep skipping over talking the histology, but if they're amelanocytic, then you have to really think about other tumors as well. And remember, melanomas are fantastic mimickers, okay? They love to imitate everyone. I know it's often said that imitation is the most sincerest form of flattery, but they really can make life difficult, not only for the patient because of the prognostic indications and all the treatments that they'll have to involve with surgery and whatnot, but they can really make it difficult to diagnose, and that's why we often can't use histologic features alone. But getting to those histologic features. So this lesion has a lot of one feature, which kind of, as I drive around, you're going to see a lot of it. There's a lot of tumor giant cells, okay? The cells themselves in this lesion are a mix of features. So mucosal melanomas can be like other melanomas, right? They're mimickers, so they like to take on various shapes, forms, you name it. So we have some really nice sinonasal epithelium with gland formation up in our top right corner, and it's surrounded by this lesion. So some of the cells are more spindled or fusiform, where they have tapered ends. They may or may not be a little wavy. A lot of the cells look more epithelioid, where they're maybe more polygonal. The cell borders are slightly better defined, and there tends to be moderate to abundant eosinophilic cytoplasm. The nuclei tend to be very irregular. They are very hyperchromatic. So we're not, again, really going to bank on getting those cherry red nucleoli that we would necessarily see in other melanomas. Look at that giant tumor cell. Okay, even if you had never seen a giant tumor cell ever, that cell definitely does not fit. It's way too much compared to all its buddies around it. And the giant cells you're going to see in almost every single case. Oops. So as I just kind of drive around a little bit on a higher power, and by higher power, we're at 10x, so we're not really high power, but, more than the 4x, more than 10x. Get in focus. You can see that in these areas, as I drive around a little bit, we're starting to get a little more of the fusiform. But the cells are still really atypical. Right? These nuclei are not round, ovoid. They're not plump like we would expect to see with reactive fibroblasts. They're very, very irregular, very hyperchromatic, and we have this lymphocytic background as well. These are often associated with ulceration. You can see necrosis in them. And the ulceration tends to complicate things because you get a lot of hemorrhage, and then you start to think about, is this really a vascular lesion? They will have LVI, or lymphovascular invasion. You can see perineural invasion, and doesn't really matter which piece I go to in this case. You're just going to see the same sea of these atypical blue cells. So just to kind of give you guys an appreciation of the depth of that. And one of the other things that you may see, and these are sometimes called specifically like the desmoplastic melanomas, is desmoplasia. So if you bear with me, there's an area up here where we can appreciate more of that desmoplasia. So if you see on, let's get a little more of a contrast. So on the right side of the field, we have the very dense blue tumor area, and then on the left side, we have more of a gray-blue, loose, almost myxoid change, this desmoplastic change. So I think it's a little easier to appreciate now at 10x. If I go to 20, again, focus. Okay, so from here you can kind of see how we have more of that looser stroma, but it is still that gray-blue that we think of for desmoplastic response. Okay, so stains for these lesions. We received the excision. We did not have the biopsy on this case, but stains that you could do for these would be things like S100 tyrosinase, and S100 and tyrosinase are definitely going to be positive in those desmoplastic melanomas, so always consider that. Obviously your Melan A or MART1, those will be positive. Your MIT-F or microphthalmia associated transcription factor, that will be positive. HMB45, so all your regular melanoma markers should be positive. Things that will really help you hone in on this being mucosal melanoma, though, are the H3K27ME3. So when that is diffuse, not patchy, diffuse, that helps you figure out that this is mucosal. Also, your c-Kit, CD117, that tends to be positive in these, and we'll get to that in a second. What's going to be negative are your keratins. CD34, if you're thinking this was a vascular lesion, and we'll just go to a different view, and also muscle-specific actin, right? Because some of those areas are more fusiform. Maybe you're wondering, hey, is this like some sort of sarcoma? We'll just go to a different area and let you guys appreciate that as I try to adjust the lighting a little bit. Okay. We are up on 20x. All right. So unfortunately, because the nuclei are so hyperchromatic in this case in particular, the features aren't necessarily helpful at higher power. Okay, so genetics. I promised you we'd talk about genetics. So with BRAF, we often see that in melanoma. So BRAF is one of the first things you're going to think of. However, it's very rarely positive in mucosal melanomas, but what is positive in about 40% of them are c-Kit mutations, right? So that tyrosine kinase, which is why our CD117 can be positive. You can also see other things like your P53 mutations and whatnot, but genetics are not extremely well classified for these lesions, and that's because they are so rare. So you might even have aberrations that are specific to your case, not even necessarily the area of the mucosal melanoma, because mucosal melanomas in the GI tract, GYN, GU, and respiratory tract are all going to have different genetics. So keep that in mind. This is what we're talking about today, again, is just respiratory, specifically sinonasal mucosal melanoma. Your differentials, particularly when they're amelanocytic, like this one, not really seeing pigment in this, is your large cell lymphomas, which should not be positive for A or melanocytic markers. Okay, and another thing to consider, then this one also has this, is the epithelioid types is, what if this is a poorly differentiated carcinoma? Well, then our cytokeratins should be positive at some point. So if you did like a broad spectrum cytokeratin, like maybe like A13, if you did like CK56 would probably be a popular one, sinonasal, so you could even consider doing something like P40. Okay. Prognostics for these are generally poor, and this one in particular has some of the features that we'll talk about that make that even worse. Mucosal melanomas, on average, survival is about 2 to 3 years if they are extremely low grade. So we're not talking necrosis. There's no LVI, no PNI. Then they may survive 5 to 8 years. But generally they're very poor prognosis. Things that are poor indicators are your lymphovascular invasion, necrosis, and polymorphous features. So polymorphous meaning, wide range of morphology. Things that have no prognostic indication. And these are important because this also differs from regular melanoma, are your overall tumor thickness, presence of ulceration, and level of invasion. So all 3 of those things matter in malignant melanoma in cutaneous and metastatic sites. Obviously, level of invasion, tumor thickness, ulceration, those are all cutaneous features, but those are things that you would consider in the prognosis if a patient had metastasis of the same melanoma. So those things don't help you at all with mucosal melanoma. Anyway, that's kind of what I had to show you with this. And these are, I think, one of the most interesting lesions for me in head and neck, simply because they have such a wide range of morphology and genetic features, and the staining is also very different and interesting. But if you like this video, hit like. If you aren't subscribed already, hit subscribe. Please let me know in the comments if there's things I missed. If you have questions about this, I'm not an expert, but I have seen a few of these, and if not, we can look at papers and someone else can chime in with information. That would be great, and everyone can learn. And that's all I have for you guys today. So thank you very much if you stuck around this far. And we'll see you next week with another short case review.